So thanks everyone for joining this evening's session. So my name is Winnie Liu. I'm a consultant interventional radiologist at University Hospital Coventry in Warwickshire. So I've been asked to talk to you about intervention and liver cancer. So we're just going to go through liver-directed therapy with you this evening. So what I would like to go through is some background on hepatic malignancies, the grading system and some treatment options. And I would like to give you an overview of the liver-directed therapy and types of different liver-directed therapy that we do and the role of interventional radiology in the management of liver cancer. So just some background about hepatic malignancy. So the primary liver tumor we treat very often is hepatocellular carcinoma and cholangiocarcinoma. There will be some rarer tumor that we treat as well, but these are the two most common ones. The secondary cancer, i.e. metastasis, would be most commonly coming from colorectal or neuroendocrine tumor or breast or melanoma or sometimes sarcoma. That's slightly rarer. And there's some chronic liver disease scoring systems. The most common one now being used are the Child-Pugh score and MEL score. Mostly Child-Pugh score has been used in staging liver cancer, particularly using as a criteria for transplantation and other liver directed therapy. So on the left table, this is showing how the Child-Pugh score is calculated. It includes things like clinical signs of ascites and nephropathy, and then tests including bilirubin, albumin, and prothrombin time. And then you add up the scores, and they will give you Child-Pugh class A, class B, class C. So Child-Pugh A basically is the early stage, B is intermediate, and C is quite advanced. And MEL score is slightly complicated. It's got some formula in it and it's shown on the right side table. Staging, particularly for HCC, those metastases would be completely different, and it's different primary cancer. So I'm mainly just going to go through staging of hepatocellular carcinoma in this talk. So I've got the OPTN staging, which is shown in this diagram, and what I particularly want to highlight to you is the Milan criteria for liver transplantation. This criteria has been used for decades and is still being used. So essentially, those are for within the criteria of the Milan criteria for transplantation is basically the stage 2 on OPTN staging, which essentially means if there is less than 3 liver lesions, which are all less than 3 centimeter, they are within criteria, or if there is a solitary lesion less than 5 centimeter, it's also within liver transplantation criteria. So a lot of treatment algorithm. The most commonly used is the Barcelona staging and treatment strategy, which has been recently revised in 2022. It is a bit complex. It will count in the patient's stage of cirrhosis, so very early stage, intermediate stage, advanced stage, and terminal stage. That actually calculated how advanced the liver disease is, and also take into account how many lesions there are, as shown on this table. And then it will then give you the treatment options. So for the early stage, we would be talking about ablation, which is a curative intent treatment, or surgical resection. And then in the intermediate stage, we're talking about patient will be referred for transplant, or could be TACE, which is chemoembolization. And then the more advanced stage, we will be looking into systemic treatments, chemotherapy or immunotherapy. What is additional to this lot is in the lower part of the table, it does mention radioembolization, which I will talk to you about a bit more details later on. So what is liver-directed therapy? It's essentially it directly targets on cancer in the liver is a minimally invasive treatment. So we're not talking about surgery. We're not talking about surgically resect one lesion. So this is minimally invasive treatment, mostly by interventional radiologists. Sometimes it can be done by surgeon during a open operation. So, for example, they can ablate a lesion within when the patient is open up. It is particularly used when the patient is not fit for surgery or disease is not suitable for surgery. And it could be standalone or in combination with surgery or chemotherapy or immunotherapy, so more systemic treatment. And the treatment intent for liver therapy, this minimally invasive method, it could be curative, it could be bridging, so meaning disease control before surgical resection or downstaging to allow them to do surgical resection. Could be a bridging before liver transplant, so we just control the growth of tumor so that they remain within the liver transplant criteria, or it could be palliative. So just a little diagram to show you the different types of liver-directed therapy that often do by IR. So on the top, we've got transarterial embolization. This essentially is going through the artery, then navigate into the liver and give some direct therapy to the liver itself, which would include bland embolization. So we put in particles with no drugs. Or TACE, which is a embolization, we put in particles which has got drugged chemotherapy loaded onto them, or SIRT, which is radioembolization. And at the bottom, the yellow is showing you the thermal ablation. So there's three energy that we mostly use. So radio frequency, or cryoablation and microwave ablation, and the non-thermal ablation are the more recent technology. So in IRE or histotripsy, which I will explain to you a bit later on. And the red is another procedure, which is a very specialized procedure. It's only done by 3 or 4 centers in the UK. I'm not currently using this, so it's essentially infusing the liver with very high concentration of chemotherapy. I will describe that method to you a bit later on. And then we've got protetic body radiation therapy, which is also counted as liver-directed therapy. This technique is not used by IR, it's done by the oncologists who deal with radiotherapy. So I won't be going through that today. So talk about ablation. So thermal ablation is what we've been traditionally using in the last few decades. So it's most often is curative. So if a lesion is quite small, we're talking about less than 3 centimeters, and they are in a place that is accessible by this thermal probe, then we will choose to ablate it because this is a intake. You essentially burn the tumor out. And the heat generated or the thermal energy generated is by 3 methods. So it's either through radio frequency machine or a microwave machine or a cryoablation machine. The choice does depends on tumor size, because cryoablation does allow us to burn out or treat slightly larger tumors, slightly more than 3 centimeters, where the other 2 mainly we treat within 3 centimeter limit. And also this could be done percutaneously or during open surgery. So percutaneously, we don't need to open up the abdomen at all. We just put a probe through the skin under image guidance. Or we do a combined procedure when the surgeon open up and resect some of the lesions they want to resect, and then we can then go in probe when the patient has got open abdomen, and then to go in with the probe with a deeper lesion, so they limit the extent of surgical resection. Sometimes the tumor might not be accessible at all. We're talking about percutaneous route. When the patient is not suitable for any open surgery, then we have to try getting to the liver lesion percutaneously. However, there's some time that it would not be suitable. For example, we've got a lesion high up under the diaphragm. It would be very dangerous to do that. Or if it's close to very important structure such as the IVC, then we might not be able to burn this lesion. So all these suitability will be discussed in the HPBMT. And the complications involved would be mainly thermal injury to the liver structure surrounding. So we're talking about any vessels or bile ducts. If the bile duct get a thermal injury, they will become ischemic and they can constrict and have a restrictor. Or you can get bile leak, or the surrounding organs could be at risk. So if you've got lesion right next to the gallbladder, the gallbladder could potentially perforate, or bowel or kidney or diaphragm, they can all the risk of injury if the tumor is very close to it when we burn it. So the type of ablation is the non-thermal ablation. So one of the technique is reversible electroporation. This is essentially to create currents between two electrodes, which we insert around the lesion, and that would then start the electric currents and the cell membrane permeable, and then they start leaking all these material from the cells, and then it causes a irreversible damage to the actual tumor cell. It is usually used to treat for tumor that's less than 3 centimeter, and you can see in the CT image in the right lower corner, it's showing you a ring enhancing lesion, and in the middle diagram, then it shows that there's 3 electrodes put into that lesion, and then once we start the electric current, it will start burning that lesion, and then the result is the right bottom image, which showing you some gas in that ablation zone. So this is normally used when a lesion is close to the main blood vessels, because instead of burning, this does not cause any thermal injury. It only burns off the tumor cells. It doesn't cause injury to blood vessels or ducts. And the other one, non-thermal ablation, is called histotripsy. So anything tripsy means that we use ultrasound wave. So the sound wave itself, when it's pointed to the liver at a very high frequency, it will kill the tumor. This is still in a phase 2 trial at the moment, and Leeds and Newcastle are recruiting for this phase 2 trial. So we're waiting to see the result of it, but this is the most recently developed technology for liver tumor. This is completely non-invasive, non-ionizing, and non-thermal, and it does not involve putting even a needle into the patient. That does need to be done under general anesthetics because it could be painful, and there's a lot of setup in theatre to do. It does give an immediate response on the laboratory model, but we wait to see the result of the phase 2. And next, we're going to talk about transarterial embolization. So the reason why we can do embolization in tumor is because of the special blood supply into the liver and into the tumor. So the normal liver parenchyma is normally supplied by portal vein, which supplies 75% of the blood going into the liver, and only 25% of blood going into the liver is supplied by the hepatic artery. However, the tumor, which generates new blood vessels forming, they are from the artery. So 95% of tumor blood flow is coming from the artery. So you can imagine if we put something into the artery, that would preferentially go into the tumor, which allow us to give localized treatment in the tumor without causing too much harm of the liver tissue surrounding. And the types of beads that we put in, it could be a bland, non-drug loaded bead, that when this is bland emulsion, or we give beads that contains chemotherapy. So this is a image diagram showing transarterial chemoembolization, but you will see the same kind of hepatic angiogram in a bland embolization. You can't tell by just looking at the hepatic angiogram, but for this case, this is a chemoembolization. In diagram A, you can see there's one blood vessel going into a round tumor. This is a very hypervascular tumor, so once we see that, we will inject the chemo-loaded bead into it, and then it will start filling the tumor, and then this tumor would start to die off with the help with the chemotherapy. So we normally follow up patients after weeks to see the tumor response with either CT scan or MRI, and it has been effective treatment for the primary liver tumor or colorectal metastases. But we mostly do this in hepatocellular carcinoma at the moment. And this, however, is not a curative intense treatment because tumor will form new blood vessels, new blood supply. So this is mainly a disease control treatment, or we control the tumor growth enough for the patient to remain on the transplant list. And next, I'm going to talk about SIRT, which is selective internal radiation therapy. It's another type of transarterial embolization, but what is different from chemoembolization is these beads or spheres will emit radioactive isotope, and it's actual radiation killing the tumor cells. So it's essentially like giving radiotherapy to a tumor, but through transarterial route. It could be done as a curative intent or bridging intent or a palliative intent. And the radioactive tracer we use is Y90, which is the most common one, and more recently, holmium. And this Y90 is being NHS commissioned treatment. It's normally done two-stage treatments because we need to do planning to know that what dose we should give to the actual tumor. So the work is we give like a ghost sphere to do some calculation nuclear medicine scan, and then once we've done the calculation and decide what dose of the actual fields we should give, we will get the patient back in 2 weeks' time to give the treatment. And those calculation has been fine to the most crucial elements to achieve good results, because we have to give the dose above 120 to be able to get a good result for the tumor. So this is a technique called hepatic infusion chemotherapy. Currently, I don't do this. It's done in very specialized cancer centers, but essentially is require one catheter to go into the hepatic artery, and the other catheter basically block off the vein before and after the hepatic vein, so that all the treatment you give through the artery, it stays in the liver, infused, and then the chemotherapy will work better than a systemic chemotherapy. So the diagram explains this. You can see the balloon in the IVC above the liver and below the liver, and then we start infusion through the machine, and it's left in the patient for about 24-40 hours to the chemotherapy running. So in summaries, the treatment for hepatic malignancies are evolving. There's new techniques coming out every few years, and it's rapidly growing area and with a lot of innovation, which all sounds very promising, but we wait to see more results from all these clinical trials. Treatment plans are very complex sometimes, and we do go up and down the treatment level from time to time. So no one treatment plan suits all, and is or discussed in the specialist center, J2B MDT. And there's lots of research opportunity if any of you want to get into, so please contact me.
Thanks, Winnie. That was a really interesting talk and a great introduction to all the treatment modalities.